review found no strong evidence that the drugs were effective. Researchers from University College London and the Royal Cornwall Hospital's NHS Trust found that the benefits of the drugs were uncertain, and many patients had side effects and withdrawal symptoms, which could be severe. Well, let's find out more about this. We can talk now to Professor Carmine Pariante, who is Professor of Biological Psychiatry at the Institute of Psychiatry, Psychology and Neuroscience at King's College in London. Professor Carmine, hello.
Hello, hi, Carol.
Yeah, good evening. And
good evening.
Also with us tonight is Professor Peter Kinderman, who is Professor of Clinical Psychology at University of Liverpool and a member of NICE, the National Institute for Health and Care Excellence Committee in the UK, but he is speaking in a personal capacity. Good to have you with us, Peter.
Good evening. Hi.
Yeah, good evening. Carmine, what do you make of this latest report, which suggests that perhaps doctors are dishing out too many pills?
The ideas that are presented in the report are not new, and to be honest, a lot of the points that the authors put across are already well recognized by the medical and psychiatric community. So, for example, we know that antidepressants should only be prescribed to patients who really needs them, so patients that have clinically significant level of depression, or depression that is been lasting for weeks or months and is having a clear effect of impairing quality of life and impairing their function. And before that, we always advocate the use of psychological or psychosocial intervention or physical exercise and try to make the patient use the available resources. Antidepressants are for the patient who needs them.
Peter Kinderman, what do you make of that?
Well, I think those are excellent suggestions. The problem is that they're not followed in practice. So we know that very, very few people who meet the criteria for a clinical diagnosis of depression, people whose problems are significant enough to warrant professional help, the vast majority of those people get offered only antidepressants and don't get any access to psychological therapies. It's certainly true that people are advised to eat properly and exercise, but most people know that that's good advice generally, and especially when you're depressed. And I think that bit of advice by a GP or a clinician doesn't make a great deal of difference. What people need when they're desperately unhappy is a referral to somebody who can help, and the vast majority of people don't get that. Instead, what they get is antidepressant medication, despite that advice, and with all of the consequent adverse effects, difficulty in withdrawing once you're on it, and very, very dubious evidence as to their effectiveness. And we see that in the number of people on antidepressants. Now about 1 in 5 of the population, generally, not only people who present with problems, but 1 in 5 of the general population are prescribed antidepressants. And the number of people taking antidepressants is doubling about every 10 years. It's really got out of proportion. And although those guideline suggestions are indeed what we should be doing, what we have to do is return to that state. And that means returning to that sort of advice, reducing the number of people being offered antidepressants and reducing the length of time that people are on them. So I agree with those sentiments. It's just not happening in practice. That's the problem.
Carmine, what's the problem here, though? Is it just that the doctors are hard-pressed and think that the easiest way of dealing someone is just to offer them a prescription? Or is it that they know that even if they refer someone to psychiatric treatment, some of the talking therapies that can be very beneficial, that they're going to have, especially at the moment, a very long wait for treatment, and that the alternative to giving them antidepressants is that they'll just be left waiting without anything to help them until they do get an appointment?
Absolutely, and I think Peter will know that the UK is ahead of the rest of the world in providing psychological treatment on the NHS, so for free, and through IAPT and similar schemes. Of course, we need more resources, and with COVID, that put even more constraint on the situation. But it's not for lack of trying, or doctors wanted to advocate this. And I think the NHS is already doing as much as they can. Also, I think it's important to there's 2 points I want to clarify. I think the fact that the antidepressant should be prescribed for shorter period of time, again, every patient has a different story. Every patient has a different trajectory. Certainly, the guidelines for someone who is at the first episode of depression, never been depressed before, is that after 6 months, maybe 9 months of full well-being, the antidepressant should be slowly reduced and then stopped. If someone has had 2, 3, 4 episodes of depression, and every time they are depressed, they stop working, perhaps they even consider taking their own life, then of course we can no longer think about stopping the antidepressant. We will have to continue for many years and perhaps indefinitely. And within this range, we have the opportunity of individual choices between the patient and the doctors. And I don't think it's correct to say that doctors are dishing out tablets, because these are choices made with patients. I'm a psychiatrist. I see patients every day, and I discuss with them. And sometimes they don't want to take antidepressant, and we decide together it's okay to wait. And sometimes they want to take an antidepressant. They're all individual choices, but taken together with the doctor.
Peter, I wonder if there's a wider problem of the medicalisation of depression. I mean, a lot of people have been through a pretty tough time over the last couple of years, and whether there is perhaps a wider willingness by the medical profession and perhaps society as well. I mean, perhaps the patients themselves are saying, I need something for this, but perhaps they just need to get out and get a bit more fresh air and exercise. I don't want to belittle the problems that some people are facing.
I'm not sure I agree with you about the just need to go out and get fresh air and exercise. But I do agree with you 100% with the medicalisation of these problems. So one of the things just in this conversation is how to square the circle with 1 in 5 of the population taking antidepressants, regardless of the really very poor clinical effectiveness for their utility and really quite nasty side effects and withdrawal profiles. The number doubling, like I say, every 10 years. And yet, healthcare professionals, NICE, Royal College of Psychiatrists recommending that we should be extremely cautious about their use. How do you square that circle? Why is it that patients are asking for antidepressants? Why is it that doctors turn to medicines to solve these problems? I think it's because we have very effectively, to be honest, been sold the message that when people become depressed, it's because they've got something wrong with their brains that needs to be fixed with medicine. And I don't think that's true. One of the announcements that we've had recently is that post-COVID, we're going to see an epidemic of mental illness. Well, partly. I mean, what we're going to see probably is lots of people losing their jobs. Unfortunately, lots of people losing loved ones, and many, many people being utterly fed up with the useless cabal of corrupt idiots that we have running this country. In that situation, to suggest that being depressed, that you've lost your job, that your lives have been disrupted, that you spent 2 years doing homeschooling, is somehow a disease that needs to be treated with medicine, is really rather bizarre. I think we need to get away from that. I think that when people's lives are in great turmoil and they are desperately unhappy and even contemplating taking their own life, I think it's not just a case of get more exercise, get out and get into nature. I think it is a case of wanting professional help, but to solve problems, to solve real-world problems in your lives that are causing great misery, and not, I'm sorry to say this, telling people that there's something wrong with them and that a pill will fix it. And that's why I think it's not just a case of reminding people that psychological treatments are available, and it's not just a case of Britain investing in psychological treatments on the NHS. It's also about considering what it is that we think we're dealing with when we see somebody in front of us who is profoundly depressed. And I think that needs to be changed a little bit. And to be honest, I think it's not only moving away from medication, it's also moving away from the idea of saying, oh, you'll be all right if you get a bit more exercise. Actually, it needs profound solutions, both on a psychological and a societal level, and we haven't taken that step yet.
And we've just had Nick in Cardiff has got in touch to say that waiting times are about 18 months for talking therapy in his patch. And, I mean, that's part of the problem, isn't it, Carmine?
Yeah, absolutely. And, I agree with Peter that this is a difficult society to live in at the moment, worldwide and perhaps in our country in particular. And it would be great if we could solve problems like poverty, discrimination, and social isolation. But unfortunately, and these are important questions, but as clinicians and people that are trying to help individuals with mental health problems, we have to deal with the situation as it is with the tools that we have. Can I just make a point? It's not true that the benefit of antidepressant is uncertain. That's definitely not true. There have been many, many studies that have shown a clear difference between using a gummy pills and using an antidepressant. Now, the effect is small, is moderate. These are not perfect drugs, and we always want to study and find better drugs, but it's not true they don't work.
The effects are very small and can be detected statistically, but clinically are much more difficult to observe. And they seem to happen after a short term. And long term, the effects are much less clear-cut.
Sorry, Peter, I just want to say, the effect is moderate, I agree. But if the moderate effect is the difference that makes for someone to be able to go back to work, or to be able to sleep better, or to be able to stop thinking about suicide, even if it's a small effect that brings them under that threshold, I think that's an important small effect. And the long-term effects are even better, are even more evident. There's been recent studies from UCL showing that actually continuing antidepressants for people who have had more than 2 episodes, so people who have a severe forms of depression with recurrent risk, people who continue to be on antidepressant don't relapse as much as people who stop. So the efficacy of antidepressant in both improving mental state and reducing the risk of relapse is being proven. If they're not perfect drugs, they can be better. They could certainly have better side effects. We should certainly stop them much slower than we used to do in the past. And if we can develop drugs that don't have side effects or that don't have withdrawal symptoms, I'll be the first to advocate for those. But just say that these drugs don't work, I think that's not correct.
Peter, I will come back to you for a very quick comment. I just want to bring in a comment that we've had from Stephen in Warrington, who says, I was on antidepressants because my wife was dying. I need them to cope. No amount of talking therapy or exercise was going to change the fact that my wife was dying. There is a place for medication to help people cope alongside the other therapies. So just perhaps, Peter, respond to that and Carmine's last point.
I would absolutely agree, and I don't disagree with what Carmine is saying about the potential benefits of the drugs for some people. My point isn't that we should forbid people from prescribing these drugs and suggest to people that that their experiences on taking the drugs and finding them beneficial is fallacious. What I suggest is that the number of people taking the drugs at the moment has become disproportionate, and that they're not, in fact, as Carmine has suggested, being reserved for people for whom they would be most beneficial. They have become drugs that have been handed out rather too frequently, perhaps without due consideration of the scant benefits for some people and the possibility of dependence on these drugs and the fact that their benefits seem to peak at the time that after about 8 weeks rather than longer. So I think it's about the proportion and the extent to which we rely on these medications to solve problems, not the idea that they should be banned entirely from the formulary. I think they should be restricted for those people that genuinely need them.
We'll have to leave it there. Professor Peter Kinderman and Professor Carmine Pariante, thank you both very much indeed. Now, Henry Bonsu is on Times Radio tonight from 10 o'clock, and he's here in the studio with us right now. Hello, Henry.
I love the way, Carol, you greet me. Such a warm, broad smile with lots of teeth.
Well, I'm so delighted to see you, Henry. It's a joy always.
Yeah, fantastic. Well, so we've got politics.